All right, good evening, Mrs. Ignacio here. We're going to go over some med-surg topics. So we will jump right in, okay? When we talk about I's and O's, intake and output, tell me what that consists of. Give me some examples.
So input is anything like they drinking. Is that the type of eyes and nose you want? Like when they drinking
Yes.
something?
Okay.
So yep. Any type of fluids they drinking, water, juice, coffee, IV fluids, anything that comes in, and the output is whatever they pee out.
Okay, good. What about output from the gastrointestinal system? What are examples of output from that system?
You mean with the little bag?
Yeah, so it could be a colostomy. Yeah, so feces defecation is an example of output from the GI system. What else?
Vomiting.
Yes, vomiting. Okay, absolutely. So defecation and vomiting are output from the GI system. Okay, GI meaning gastrointestinal tract. So I like what Tonya said is anything that's coming into the body and then anything that's leaving. So when we think about the intake, it could be by mouth, it could be IV, it could be, maybe they're getting TPN, right? But that's all into the body, and anything that's coming out, it could be perspiration, it could be urination. But when we think about the GI tract specifically, defecation and vomiting are coming from the GI tract. When you think GI, think everything from the mouth to the anus. Okay. And we know when we have a patient that has vomiting and diarrhea, we're concerned about their hydration status, right? We're concerned about their fluid electrolyte balance. Okay, so that's another important, kind of NCLEX thing that you should remember. Okay, something that you also need to remember about intravascular fluid in the body. When we think about intravascular fluid, and I'm also going to put that term in the chat in case you want to write it down. This intravascular fluid, it contains plasma, proteins, and red blood cells. Okay, so when we think about intravascular fluid, that's what you need to be thinking about. Okay, it contains plasma proteins and red blood cells. Okay, so any questions so far? Okay, all right, so if I were to ask you to list, and I'm going to try to put this in the chat. If I was to ask you to give me a list of hormones in the body that promotes water loss, okay? Okay, so which of the following hormones in the body that promote the loss of water and sodium ions from the kidneys, from the kidney tubules? What would those hormones be? Okay, there's two of them in particular that I'm thinking of.
I think it's the B type neutral peptide.
That's right, Miss Linda, you got it. Okay, you've got it.
I don't know the other one though. I just remember that one.
Okay, well, that's good. Okay, I'm going to put the other one in the chat. It's going to be the atrial natriuretic peptide. Okay. So that's going to be important to note, okay? Those are the two that really, those hormones help to promote the loss of water and sodium ions through the kidney tubules. And I'm not going to go into the whole, loop of Henle and all that other stuff from A and P, but those are going to be important because we sometimes will take those as lab values for our patients, okay? So that's something that you need to remember. And for those that are getting ready to take the NCLEX, because we do have someone in the group that's going to take the NCLEX, it's a good idea to make sure that you're looking at your lab values and what they mean to, and not only just memorizing the numbers, but okay, what does the lab value mean for the patient? And for the med-surg students, that's also a good idea as you are learning these lab values. You know, what do they mean and how will the patient present if their lab values are out of whack, or what do I need to look for? Okay. All right. The next concept I want you to know is when you are assessing the fluid volume status of your patient, and we're thinking about the intravascular volume. Okay, the best thing that we can do is take blood and a chemistry panel. That's going to tell us really what's going on with the patient's blood. And so that's going to be, right, your CBCs, and we're going to be looking at, you know, not only the blood, but we're going to be looking at those electrolytes. So that's going to be really important. If we take the blood and the chemistry panel, that's going to tell us the really, you know, what's going on with our patient. Is going to give us a good assessment. Okay. All right. If you have a patient that is suffering from dehydration, what kind of lab values would you expect to see? Anybody?
Hyponatremia.
Okay. Did you say hypo or hyper?
N- Hyponatremia.
Yes, that is correct. That is excellent. If your patient is dehydrated, you would expect to see high levels of sodium. Okay, for sure. Okay, that's going to be one of the key indicators that you would see. Okay, awesome. Awesome. Okay. All right. If you had a patient that was in fluid overload, if you have a patient experiencing fluid overload, what would they look like to you? And you can tell me anything, lab values, physical presentation, what would they look like?
Swollen.
Okay, good.
You know,
Swollen. And what is that nursing word for swollen?
Edema.
Yes, edema, right? And so this makes me think of my left-sided and my right-sided heart failure patients. Okay, what else? While I'm pulling up a patient, okay, so Shamiqua, so you put edema, very good.
Yes, she put edema. I steal it from her.
Okay, good. Okay, great. I'm trying to get my pictures up, so I didn't see that right away. All right, what else? Fluid volume overload. What is your patient gonna look like?
they might sound like they might have some wheezing or some sounds in their chest because of the fluid value overload.
That's right. So they may have, and so you're thinking of your left-sided heart failure patient. So let me just jump to that real quick and I'll come back to my right-sided because you mentioned that. So you're describing, Tonya, your left-sided heart failure patient. Where is my left-sided guy? Why don't I see him? Oh, here he is. Okay. So yes, so fluid volume overload, I'm thinking congestive heart failure patient. I'm thinking if it's left-sided heart failure, they've got fluid volume overload, they're going to have coughs, crackles, wheezing, blood-tinged sputum, tachypnea, meaning that the heart rate is over the normal. Remember the normal? I'm sorry, not their heart rate, their breathing. Remember their breathing is 12 to 20 respirations per minute. And so if they have tachypnea, they're going to have more than 20 respirations per minute. Okay, so this is left-sided heart failure, but this patient I would expect is going to be in fluid volume overload. Okay, so let's go back to our right-sided heart failure patient. Okay, and so this patient is going to be the epitome of fluid volume overload. They're going to have a weight gain. And that's why daily weights is important for our CHF patient and patients that are at risk for fluid volume overload. Daily weights every morning after they empty their bladder. Right, that's going to be the best time to weigh them. The patient may have edema, as you all already said, and they may have crackles in their lungs. They may have JVD, they can have ascites, right? So these are all things to look for in your patient with fluid volume overload. Again, weight gain, edema, crackles in the lungs upon auscultation, okay? All right, let's talk about the opposite of this, dehydration. So Linda already told us that our dehydrated patient is going to have high levels of sodium. What's their blood pressure going to be like?
I think they get the low blood pressure.
That is
Um,
correct, Tonya.
Okay.
Yeah,
I'm
go
trying to
ahead.
think of the proper name.
Yeah, okay, I'm going to put it in the chat. I'm going to put it in the chat.
Yep,
Hi-
hypotension.
Yes,
Yes.
hypotension. That's right. So I'm glad that you're thinking of the proper name because that's what you're going to see, right, for NCLEX. So hypotension. So that could be, again, your patient experiencing dehydration. Okay, so if you have a patient that has shifting of fluid from their intravascular spaces into their interstitial spaces, like in the tissues, that will result in edema. This patient that has this edema because the shifting of these fluids, I'm concerned about their plasma proteins. And particularly the value that I would look for is going to be albumin, right? Because albumin tells us the protein level in our patient. If your patient has this edema, this shifting, I would expect, and I would expect that when I look at their albumin levels or their plasma proteins, that it's going to be low because these plasma proteins actually are what keep the blood in the blood vessels where it belongs. Okay. Any questions about that? All right. Let's talk about edema. So what do you all know about edema?
Do we measure it by,
Go ahead.
do we measure it by the pitting?
Yes, we do. Very good, Shamiqua. Okay. So here's a picture of your pitting edema. And so it's 1 plus, 2 plus, 3 plus, 4 plus. So that's your, your types of edema. As the numbers increase, it's going to be more serious, right? So when we think about pitting edema, let's talk about 1 plus. So this is a slight indentation, okay, with no perceptible swelling of the leg. If we have 2 plus pitting edema, there's the indentation subsides quickly and the leg is perceived as mildly swollen. Let me see if I could bring that up a little bit so you can see it. And if we have 3 plus pitting edema, the indentation remains for a short time and the leg looks swollen, right? And swollen edematous. And then 4 plus pitting edema, the indentation lasts for a long time and the leg is very swollen. Now there is something that's not on this, which it could be weeping edema, which is very painful. Okay, yes, Thais, I see you. Fluid accumulation in the lower limbs, right? The lower extremities. So weeping edema, this patient, the actual fluid is coming through their pores and this is going to be extremely swollen, okay, and very painful. So one of the things that we're going to do are independent nursing actions. If a patient has this edema, we're going to elevate their extremities. Elevating the legs will help return the blood flow back to the heart, okay? Will help return the blood flow back to the heart. Any questions on pitting edema? And it's best assessed over the shins, okay, over the shins, okay. If you had to give your patient some intravenous solutions, one that doesn't have electrolytes, what would you give? This is a kind of a tough question, I think, actually. Hypotonic,
Is
is
it
it vitamin?
dextrol solution in water?
Yes, that is correct. Okay, look at you. Okay, go ahead.
I read the chapters. That's why I came across the.
Okay, no, that's excellent. So yes, dextrose in water doesn't contain any electrolytes, and that would be an appropriate solution. Okay, normal saline, we know that it has Na and Cl. That's your sodium and chloride, and those are electrolytes. So if you had to give your patient an IV solution without electrolytes, it would be dextrose in water. And actually, dextrose is going to be a hypertonic kind of solution. Okay, let me just get Alexa. Okay, thank you. Oh, she's gonna unplug Alexa. All right, great. Thank you. All right, so dextrose and saline does contain sodium and chloride. Lactated ringers does contain electrolytes found in the normal plasma. So that's a solution that does have electrolytes as well. Okay, so let's talk about the next topic. Let me pause for a second. Anybody have any questions? All right, so if you have a patient that is abusing antacids, they're taking multiple antacids every day, what kind of electrolyte disturbance do you think they're going to be at risk for? Potassium, okay, so I see potassium. Okay, so is it going to be high or low potassium? Actually, low. No, if they're taking antacids, they're not, it's not going to be potassium. Okay. It's actually going to be magnesium. They're going to have too much magnesium. Okay. So let me see. So they're going to be at risk for hypermagnesemia if they are abusing antacids. They also may be at risk for hypercalcemia, too much calcium, because we know that these antacids have calcium, a lot of calcium in them, right? So if you see this again, know that it's not hypocalcemia, it's hypercalcemia and hypermagnesemia. And if you have any antacids in your cupboard at home, it would be a good idea just to take a look at that, because this is something you could definitely see for NCLEX as well. And I feel like if you look at it, you're like, oh, this is what's in antacids, right? So this is your Tums or your Rolaids, anything that you would have for, heartburn or GERD or something like that. That might be helpful to you to see it in person. Okay. All right. Any questions so far? Okay, we're going to go talking about respiratory acidosis and respiratory alkalosis. So I'm going to be bringing up some pictures. I think I'm still sharing my screen. So let's go under respiratory. Okay, so respiratory. Let me see, why is it? This is not the thing that it's under. I think it might be under acid-base balance. Let me see. No, that's not the one that I'm looking for. There's so many of them I forgot. Let's see. It should be under respiratory. Why is it not showing up? Asthma, tonsillectomy. Yeah, it's not under this. Types of oxygen. Okay, let me just Google it real quick. Because I want to make sure you know the difference between respiratory acidosis and alkalosis. Okay, so this is a good picture that has all four of them. Okay, all four are the ones that we need to talk about. Okay, so let's talk about respiratory acidosis first. Okay, so when we think of respiratory, I want you to think of CO2, carbon dioxide. And if your patient has respiratory acidosis, they are holding on to carbon dioxide because carbon dioxide is an acid. Okay, and so they are retaining carbon dioxide. This could be your COPD patient, and you see this patient here with their respiratory. They look like they're doing some pursed lip breathing. So they're inhaling in through their mouth, and then they're in through their nose rather, and then they're blowing out through their mouth. So this patient that has respiratory acidosis, hold on, this is not. This is a double picture, okay? That's why it's not showing, it's just showing acidosis, okay? I thought it was showing alkalosis. I was like, wait, that's not right. Okay, so sorry about that. When we think about respiratory acidosis, this is your COPD patient. Again, any patient that is not able to get out all of the carbon dioxide because increased levels of carbon dioxide cause respiratory acidosis, okay? So just because that's what we have on this picture, we'll talk about the acidosis and then we'll go to the alkalosis. All right, so think respiratory, think lungs, think too much carbon dioxide, okay? When we think about metabolic acidosis, I want you to think metabolic, think kidneys, think about this patient that has warm flushed skin, they may have nausea, vomiting, they may have Kussmaul respirations because they're trying to compensate. They have, and with both acidosis, the pH is going to be less than 7.35, right? Because the normal pH that we live within is 7.35 to 7.45, okay? So when we think about metabolic acidosis, this can be caused by shock, by diabetic ketoacidosis, renal failure, and diarrhea. Okay, so those are some of the potential causes of metabolic acidosis. Okay, any questions on the acidosis, metabolic, and respiratory? All right, let me see. And I just put a little blurb in the chat. Let me just find the respiratory and metabolic alkalosis picture because that's going to be the opposite, right? Respiratory. Okay, here we go. And I'm going to have to start closing some of these tabs. Okay, so here we go. When we think about the alkalosis where the patient is too basic. And so what's happening with respiratory alkalosis, this patient could be hyperventilating. So in the movies, you see them saying, hey, breathe into this paper bag because they need to get more acid. So they need to breathe in their own carbon dioxide. So when a patient is at risk for respiratory alkalosis, they can have seizures, they may have tachycardia, low or normal BP, and some of the causes, right, and all of the other things that you see here. Now, some of the causes for respiratory alkalosis could be the hyperventilation or anxiety or panic. If a patient is having a panic attack, a pulmonary embolism, or even if they're mechanically ventilated, they're at risk for that respiratory alkalosis. Let's look at metabolic alkalosis. Again, too much base. So this patient will be restless. This patient will be the one that could be NG tube to suction. This patient may be vomiting. So this patient is losing all of their stomach acid. That's why how they become alkalotic. Okay, and so one of the telltale things that we're looking for also in a metabolic alkalosis patient is tremors, muscle cramps, tinglings of the fingers and toes. Okay, so that's just a quick kind of down and dirty on respiratory acidosis, metabolic acidosis, metabolic and respiratory alkalosis. Any questions between the differences between those four things? Okay, I guess that means everybody is okay. Okay, that's pretty good. I know when I was in nursing school, I didn't quite understand it, and I just wish that I didn't get any questions on it. But hopefully these, because I don't remember having these visuals when I was in nursing school, but hopefully they help you understand it a little bit better, because it is a really important concept to grasp. Okay. All right, so I don't see anybody saying anything in the chat, so I'm going to continue. So the next question I have for you is a kind of a scenario. A patient is in acute respiratory, distress, and okay, and they have deoxygenated blood returning to the left side of the heart. Is this normal or abnormal? Deoxygenated blood returning to the left side of the heart. Normal or abnormal? Yes, it is abnormal. Shamikwa is correct, because we know that the left side of the heart should be receiving oxygenated blood, and that abnormality is called shunting. Okay, it is called shunting. Okay, that's going to be an important term to remember. It's called shunting, and that is abnormal. Deoxygenated blood enters the heart on the right side. The blood that's entering on the left side should be oxygenated. Okay, let's talk about strep. What can you tell me about strep, streptococcus? How do I know my patient has strep throat?
Swollen tonsils.
Okay, yes, Crystal. So there may be some edema, some redness when we look at the back of their throat. Very good. What else might they have? All right, let's see here. Okay, yep. So this is a good one. Okay, so here we got the tonsils that Crystal mentioned. What else could I see? The white patches. I could see the white patches. Pus. Okay, yes, that's what Shamika said. Okay, reports of not being able to swallow. Okay, great. So you all got it. So this streptococcus infection, right? Where I'm going to do this rapid strep test. It is caused by the Streptococcus pyogenes infection. So that's the name of the bacteria, right? Streptococcus pyogenes. And so we know that this is treated by antibiotics. And we know that this kind of strep throat, if it's untreated or if it's not treated properly, it can lead to damage of the heart, and it can also lead to damage of the kidneys. And I think when we discussed this in class, I mentioned little Johnny that had strep throat, but the little sister, little Susie, 2 weeks later has possible heart issues. Scarlet fever, I think, is what we talked about in class, right? We know that scarlet fever can be caused by an untreated strep infection 2 to 6 weeks after exposure to strep. Okay, so understand that this Streptococcus pyogenes can cause this strep throat, which can lead to heart and kidney problems. And so we will use a rapid strep test. Okay. If you have a patient that is coughing and they're getting tired, what kind of medication would you expect to see? Uh, Not necessarily pain meds, but if they're coughing and they're getting tired, like if they're really, really coughing, they just can't stop coughing, we're going to give antitussives. Okay, antitussive agents are used to inhibit this cough reflex center in the brain. Okay, so that's why we would give these antitussives. Okay, so we also, when this patient is coughing and coughing and coughing because they have all of this mucus, we want to also make sure that we increase their fluid intake because that's going to help to thin the secretions. Just like humidified oxygen will help to thin the secretions, pushing fluids will help in this patient's case. But these antitussives are used to inhibit that cough reflex. Okay, that's going to be important to understand. All right. Let's go to the next thing, and I don't see any questions. I'm trying to look at the chat. I don't see any questions. Let's talk about chronic lung diseases. 30, what's 300 mLs? So if I'm pushing fluids, 30 mLs of urine per hour, if that's what you're saying. But pushing fluid, there's not necessarily a number. So, oh, you're thinking 2 to 3 liters per day, probably 2 to 3 liters per day. I think that's what you're asking. Yes, and that's going to be good. So we want the patient to drink 2 liters of water. Okay, yes, okay, I get it now. So 2 liters of water, but if we're pushing fluids, depending on, the situation that we're pushing, so 2 to 3 liters. So that's good if a patient has the extra fluids, if the patient has a kidney or a urinary tract infection, yes, though that amount of fluid is what we're talking about. So that's a good number. Okay, let's talk about a patient that has chronic lung disease such as emphysema. So I'm now going to go to my pink puffer. Okay, here we go. All right, so when we think about COPD, we know that COPD has 2 branches. There's chronic bronchitis and there is emphysema. So my emphysema patient is my pink puffer. I know that this patient already is going to be at risk for respiratory acidosis. They're holding on to the acid. Because they're not able to get out all of their carbon dioxide. They're going to be practicing pursed lip breathing. All of that goes with this patient that has COPD. They're also going to experience hypoxemia. Hypoxemia. That, anybody know what hypoxemia is? Okay, I see. Okay, Shamikwa, great. So hypoxemia, low levels of oxygen. That's right. So very good. Okay, very, very good. So when we think about this patient that has this chronic lung disease like emphysema, we know that their hypoxemia actually helps stimulate their breathing. Okay, so hypoxemia. When a patient has hypoxemia, low levels of oxygen, then we would see things like clubbed fingers, right? We will see in this COPD patient, we will also see orthopnea, that barrel chest. And remember, orthopnea, they have to be in an upright position in order to breathe. They can't lie in the supine position. Okay. Awesome. Okay, yes, they will have that barrel chest. Good job, Thais. I see you. Okay, excellent. All right, let's shift gears now and talk about uncomplicated influenza. Okay, if your patient just has a regular kind of flu, one of the interventions we could do for them is to have them gargle with saline, right? Because that will help their sore throat. Okay, that's going to be one of the things. What else can we do for a patient that has uncomplicated influenza? Well, let me ask you this. Should they be taking antibiotics for uncomplicated influenza?
No.
No, absolutely not. Antibiotics is only for bacterial infections. Should they decrease or increase their daily fluid intake? Oh, Linda, can you say that again? I don't think I heard you.
No, I didn't say nothing.
Okay, so yes, Shamikwa says increase. Yes, increase because we want to thin the secretions, we want to rehydrate them. So this is not a patient that should decrease their daily fluid intake. Okay, and we should, if they have a fever, we should give an antipyretic. We don't want their fever to run high, right? If they have influenza. Okay, so we want to treat the symptoms of our patient that has this influenza. All right, let's talk about a patient that is in respiratory failure. What are some of the signs and symptoms that I would see if a patient is in respiratory failure? Okay. Okay, so I would give them oxygen therapy. Absolutely. Okay, so when we think about respiratory failure, I want you to also think about their arterial oxygen. Okay, their arterial oxygen. So when we think about those ABGs, which is separate from our O2 sats, arterial oxygen for a patient needs to be between 80 and 100. Okay, arterial oxygen needs to be between 80 and 100. If your patient has an arterial oxygen that is below 50, this is a cause for contacting the physician. This is a cause for, okay, this is a critical patient, right? That they're at risk. Okay, they're at great risk. Okay, so again, arterial oxygen should be between 80 to 100. If it's below 80, I'm calling the doctor, I'm calling my nursing, supervisor, I'm calling everybody because this is a pretty significant development in the patient and they're at risk for respiratory failure. Okay, any questions about that and those values? Okay. Let's talk about a bronchoscopy. Anybody tell me what are some of the nursing considerations if your patient is having a bronchoscopy? Nursing considerations for bronchoscopy. Nursing considerations for bronchoscopy, anyone? And it's totally fine to look in your book if you're not sure.
I answer some if you want.
Sure.
Oh, no. No, I'm sorry. So some of the considerations when they have a bronchoscopy is you're gonna assess for bleeding, right? You're
Okay.
gonna prevent aspiration, like you're gonna position the client semi-foulers.
Okay, at least semi-foulers, yes, because they won't be supine, so that's correct. That's good.
You want to monitor the vitals, right? With any surgery or procedure. check respiratory.
Okay.
That's all I remember.
Okay, so that's very good. Okay, so what about their gag reflex?
Oh yeah, for sure. You're gonna check that before you give anything.
Okay, absolutely.
Medicine.
Right? So before I give them any food to eat, before I give them anything by mouth, I need to assess their gag reflex. And if they, yeah, so Thais says keep them MPO. So very good, Lakeisha and Thais. Yes, I'm going to assess their gag reflex. If I don't assess their gag reflex, then I better not be giving them any food or anything to drink, okay? Because the idea is to keep them safe. Okay, very good. Let's talk about a thoracentesis. What are some of the things that the nurse should do during the thoracentesis? And anyone can answer.
So that's the removal of fluid off your off your joints.
So from the
Nico.
thorax, okay, so from the thorax, yes, from the lungs. Okay, very good, Thais said. Yes. So what are some of the things the nurse should do during this procedure?
Monitor the O2 levels.
Okay, yes, that's a good thing, Crystal. Okay, yes, so Thais says a needle is inserted through the chest. That's correct. Crystal said to monitor the O2 levels. Lakeisha said get those vital signs and make sure that we take those vital signs immediately before the procedure, and during the procedure, we'll be monitoring their vital signs. How is the patient going to be positioned for a thoracentesis?
Are they gonna be sitting over the head table or over bed table?
Yeah.
Yes, that is correct, Linda. So the client is going to be sitting and leaning over the bedside table. Okay, so that's going to be very important. Okay, so before the procedure, the client will sign the consent form. That happens before the procedure. Okay, so that's going to be something to keep in mind. So understand what happens before, during, and what about after the procedure? What are you concerned about? So after the procedure, what are you concerned about? And anybody can answer.
Would it be lung sounds?
Yes, Crystal, I love the way that you're thinking. So that tells me you're going to auscultate or you're going to perform a respiratory assessment. That's going to be really important, right? When we think about the nursing diagnosis, assessment, that focused respiratory assessment. Okay, fantastic. Okay, and of course that patient's going to be on eyes and nose, intake and output. We're going to monitor that very closely. Okay, so talk to me about fluoroquinolone is an antibiotic. What are some of the adverse side effects of this medication?
Is it hypoclampsia?
It's hypo something, but I'm not sure what.
Hypokalemia? I don't know. I don't know.
That's okay.
I tried.
Okay, that's good. So, you all can be looking this up too and writing it down. So I'm putting it in the chat to make sure that you
Okay.
are looking it up. So fluoroquinolone, right, we are concerned about hypoglycemia. Okay,
Okay.
we're concerned about hypoglycemia. That's one of the potential adverse side effects that we need to understand and monitor our patient for. And understand that fluoroquinolone is an antibiotic and it treats bacterial infections. Okay, it treats out bacterial infections. All right, let's shift gears and talk about epiglottitis. So I'm sharing my screen and you should see the epiglottitis person, okay? And whenever you see itis, think inflammation, and this is going to be an inflammation of the epiglottis. And what we need to look for, what do you think by looking at this? What's some of the things?
Airway.
Yes, that's the first thing, Linda. I like how you're thinking. What else? So besides airway, and here's the picture of your patient with epiglottitis. What are you going to do? What are your nursing interventions? What are you looking for? What is the patient going to look like? Okay, so Thais says swelling, right? Because I'm getting super concerned because we know that epiglottis is the flap that protects the airway. If that epiglottis becomes very swollen, it could block the airway. So we want to continue to monitor the patient for signs and symptoms of respiratory distress. We need
Okay.
to make sure that we are ready with an artificial airway. We also want to make sure we get a full set of vital signs. And I'm really going to be focusing on that oxygenation, right? That's
Okay.
going to be important. Okay, this patient's main goal, like Linda said, is to maintain a patent airway. Do not stick anything down their throat. Okay, this epiglottitis is a really good NCLEX question that you should definitely don't forget this when you're taking the NCLEX. Okay, this is a really great, this could be a select all that apply question. This could be a drag and drop question. This could be a part of like a case study. So epiglottitis is a really good kind of question. Okay, let's talk about infection in our older adult. What are some of the signs and symptoms that I could see in my older adult that has an infection?
Is it fever?
Okay, yes, fever is one. And what else? If we think infection in our older patient. Okay. So we think of infection in our older patient. What about confusion, altered mental status, right? This is going to be a sign of infection in our older adults, okay? And welcome, Maria Isabel. We haven't started maternity yet. We're just wrapping up med surg right now. So you're welcome to stay until we shift gears to maternity, okay?
Okay, that's fine. That's fine.
All right. Thank you. Glad you're here. All right, so when we think about our patient that has an infection, if they become confused, if they have a fever, right, those are all telltale signs of, okay, this patient does have an infection. And again, you're going to see this particularly for your geriatric patient. Okay, so what is empyema? Okay, yes, Thais, you're right. When you said foul urine, that could be a sign of infection as well. Okay, what is empyema? Anybody have any ideas? Empyema, and you can feel free to look it up.
Is it pockets of pus that have collected inside a body cavity?
Yes, very good. Okay, and so it's thick and it's purulent. It's pretty nasty. Okay, it's pretty nasty. Okay, so if your patient has empyema, what's going on?
An infection?
Yes, it is an infection. Okay, and so where is this infection? If a patient has empyema, where is the infection? Okay, so Thais says the lungs. That is correct. Okay, so if your patient has empyema, this is exactly what Crystal said. And the cavity that she was referring to is the pleural cavity, and that's within the lungs. And this discharge becomes thick and purulent. Okay, so let's talk about the chest tube. Okay, I'm going to stop sharing for a second because I'm going to bring up my chest tube handout. Who can tell me anything they know about chest tube and chest tube care? Anybody know anything about chest tubes? Anybody know anything about chest tubes? Okay, so Thais says it has to be free of kinks, so that's good.
They promote drainage.
Okay, yes, that's true. It promotes drainage. Okay, that's great. Okay, and this is kind of like an old style thing here. Let me try to get a better picture of a modern one with the different kinds of chambers. Okay, because you need to know the different chambers. Definitely for NCLEX, not necessarily, but let's take a look at this one. All right, well, I'll just use this one as an example. All right, so here is what a chest tube looks like. Okay, these three columns right here, that's going to be the collection chamber. And so you see that this fluid here is serous sanguineous or serosanguineous, right? And just remember what those terms mean. And we will mark it off, and we have to document this as output for a patient every 4 hours. That's going to be important to do. At the bottom, you see here, you see there's something in the chat. Okay, yeah, so Thais says keep it below the level of the chest. So right here, what I'm circling in pink, that is going to be the collection chamber. Below right here, this is going to be the water chamber, And if there is continuous bubbling in the water chamber, that tells us that there is an air leak somewhere. Okay, this next chamber that I'm circling, this is the suction chamber. And it's okay for there to be a gentle continuous bubbling because that's actually the suction. Okay, that is the suction chamber. Okay, if you see, if they're asking about titling, That's just a gentle flow of the water, of the fluids when the patient is breathing. That's okay. But if there is a persistent bubbling in the water chamber, right, we need to make sure that we are looking for an air leak. Okay. So in the suction chamber, you may see that bubbling, right? Now, this bubbling is going to kind of be in line when the patient is breathing. So you should see the bubbling as the patient inhale, exhale, but it doesn't necessarily have to be continuous. It can be intermittent, okay? But again, if there is continuous bubbling in the water seal chamber, that tells us that there is an air leak, okay? Any questions about this chest tube? Okay, awesome. Let's continue. Where can you monitor your patient's O2 saturations? Where are all the places?
In the forehead,
Okay, yes, the forehead. Where else? Okay, well, that's going to be something that you can definitely look up. Where would all the places be that you can assess your oxygen saturation for your patient? Okay, so the next thing that we're going to go to is when you are assessing your patient and you are performing a ventilation scan. Okay, when we are performing a ventilation scan. What is the procedure? How do we do this ventilation scan? Okay, so if the patient is having a ventilation scan, they are definitely going to be asked to hold their breath for short periods of time. We need to make sure that the patient has a patent IV access. And there's going to be a small amount of radioactivity for this particular scan, but it's not anything too extensive, okay? All right, let's talk about intranasal zinc. What do you know about intranasal zinc? Okay, definitely look that up. That's going to be something that you need to know. Talk about, you need to know what happens with a patient that has sinusitis. What does it look like if a patient has sinusitis? What are the risk factors for sinusitis? Okay. Also, the signs and symptoms of throat cancer. What are those signs for cancer? And I think we talked about this when we think about cancer. What are some of the things that we're going to be looking for? Wrong picture. Okay. Oh, I should have clicked on cancer. So what are the signs and symptoms of cancer? And we should know these different signs and symptoms when we think about the various types of cancer. Okay, hoarseness, yes, for more than 3 weeks. Okay, so that's great. That could be a sign of throat cancer. Okay, so that's great. So understand what we're looking for. Okay, all right, let's talk about Tuberculosis. What can you all tell me about tuberculosis?
It's airborne. Oh, sorry, put that.
Yes. Okay. Yep. You said it at the same time. So that's perfect. Okay. So airborne precautions. The patient may report shortness of breath, low-grade fever in the afternoon, and they may have weight loss, right? So all of those things go with tuberculosis. They may have this fatigue, again, anorexia, weight loss, chronic cough that's productive, night sweats, hemoptysis in the advanced state, and pleuritic chest pain. So, and I think we talked about in class this, the TB skin test, the chest x-ray and the sputum studies were looking for acid-fast bacillus. Okay, acid-fast bacillus. Okay. What if you have a patient that presents to the emergency department and they don't, they're in respiratory distress and they don't have wheezing? What do you think is going on? Okay, so let me ask it again. So if your patient comes to the emergency department and they're in respiratory distress and they don't have wheezing, what do you think is going on? So not necessarily an allergic reaction, but that was a good guess. Respiratory distress without wheezing. If they have asthma and they're in respiratory distress without wheezing. Yes, Lakeisha, that's right. What is going on? Okay, so for my class, yes, Lakeisha, I like that. Okay, so for my class, they're gonna have to look it up and let me see. Okay, so when you're breathing room air, what percentage of oxygen are we breathing?
$21.
Yes, that is correct. 21%. Okay. When we're breathing room air, we're at 21%. Okay. All right. What is the medication loratadine used for? Okay, very good. Okay, so yes, it is used for allergies. So what you also need to know is the patient teaching. What can the patient do? Is there any dietary restriction with this medication? Okay, you have to understand the signs and symptoms of the common cold. And you also have to understand the side effects of albuterol as it goes with your fluid electrolytes. Okay. Your albuterol, fluid electrolytes. How does it affect your fluid electrolytes? Okay, if your patient is suspected of having a PE, what blood test am I going to focus on that tells me that the patient is having a PE, pulmonary embolism? What blood test am I going to look at? Okay, you need to understand tracheal deviation, what that actually would look like in your patient and what would put them at risk for tracheal deviation. What kind of activities, recreational activities, or other things that could happen to the patient that could cause tracheal deviation. We talked about COPD. Okay, let's talk about our SIM ventilation. Okay, if the patient is on a ventilator and they are in SIM V mode. Okay, so when we think about SIM V mode for a ventilator, this patient is receiving mechanical ventilation. And so when they're in SIM V mode, the patient is able to breathe on their own, but also will give them a specific predetermined number of breaths to make sure that the patient will still get the oxygen that they need. Because even though the patient may be able to breathe spontaneously, they may not be able to continue to do so because they may end up getting fatigued. Okay, so that's what SIM V mode means on a patient that is on a ventilator. Okay, all right, we talked about pursed lip breathing already. And I think that is going to be it. All right, I'm going to stop sharing, stop recording.